If the patient stops breathing, begin pulmonary resuscitation. If both breathless and pulseless, begin CPR. And you guys are all CPR certified, right? Yes?
Yeah.
Okay. So what is the compression to breath ratio now? Is there any, or is it just boom, 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 boom? It's all chest compressions, right? Okay, because what's the purpose of the chest compression? Continuous blood flow. If a reaction occurs, this is documentation now. If it occurs, you want to, it says film jacket. Wow. Film file. Note that in the patient's record. There has to be a system in your hospital where if a patient does have an allergic reaction, it is automatically red tagged so that when their name comes up again, it's right there in your face as an alert. Okay? The radiologist or the physician should document it also in the patient's chart, and the radiologist should note reaction in his or her dictated report. Okay, again, we got to red flag it, so that way if they come to us again, we know what to do. But we should be prepared anyways, right? Universal precaution. Okay. Post-procedure, keep patient in the department 30 minutes after contrast has been injected for observation because the possibility of what? A latent effect, so there's a possibility. So keep them in your department even after the procedure. Patient should be allowed to go home after 30 minutes accompanied by another person. They should be educated of the signs and symptoms of anaphylactic reaction or any type of latent effects and instructed to return to the emergency room immediately should those signs demonstrate. Types of anaphylactoid responses. So this is how your body responds systemically with the contrast reaction. We'll do skin, GI, central nervous system, respiratory, and so on and so forth, okay? So in your skin, the response to contrast, you may have mild urticaria, itching, pallor. What's pallor? Okay, so you get pale, exactly. Mild angioedema, so there's a little swelling there, and then your intermediate response, okay, and then no major responses to skin. Gastrointestinal, you have nausea, vomiting, severe nausea, vomiting, and also diarrhea. CNS, minor, includes headaches and dizziness. Intermediate response to your central nervous system is, what's it, aphasia? Okay, unable to speak? Unable to speak. Yeah, aphasia, okay. And then worst case, you can have seizures, paralysis, paralysis, unconsciousness, and also coma, okay? And then you guys can read that. Respiratory, okay, sneezing and wheezing, but worst case scenario, you stop breathing. Cardiac, you may have some tachycardia, chest pain. Worst case scenario, you have a heart attack, okay? So this is a good chart to refer to in the response, the different type of responses to the contrast media. So be familiar with this chart. All right, so just look through it. Okay, chart, it's a good chart. These are some great pictures. Okay. There's a GI response. Just look at this real quick. Phenergan, promethazine. I know these two will be mentioned in your test. So both Phenergan and Zofran. Zofran is an antiemetic drug. Antiemetic. What's emetic? Okay, throwing up. Okay, so this will prevent any type of nausea or throwing up, vomiting. So those are the two types of medications that would be good for the GI response. Oh, there we go again. All right, CNS response. So each of these responses, you'll notice there are some drugs that are suggested to use. So here is another one, diazepam. Everybody knows what that is. It's Valium. Okay, so that treats anxiety, muscle spasms, and also seizures. Cardiovascular response, so minor tachycardia is going to be the most common cardiovascular response, so a fast heart rate. Intermediate is low blood pressure with a fast thready pulse. You may also have bradycardia. So now if you have hypotension and bradycardia, that is a bad combination because your blood pressure drops, your heart rate is slow. Now blood isn't pumping anywhere. So your body's not doing what it's supposed to do because as a response with low blood pressure, you should have increased heart rate. And if that doesn't happen, okay, this is bad stuff, okay? This combination, this is bad. Okay. So again, relieve by placing the patient in a semi-Fowler's. If not, try to get their legs up. We're trying to get blood back into the heart. Here we're trying to increase the capacity of your lungs. We said atropine was good for what? That was like 10 slides ago. It's good for bradycardia. Okay, so atropine is good for bradycardia. Okay. Now, here are the other drugs. So here, hypotension with bradycardia, atropine is good. Hypotension with tachycardia, epinephrine is good, also known as adrenaline. I think I'm getting old. I was I just found out another one of my friends had a heart transplant. Yeah.
You bring them bad luck.
He's
Like
actually, who's at St. Jude's? You know Vince?
No, I haven't met him.
You haven't met him yet? Who's at St. Jude's?
Vince, yeah.
You know Vince?
Yeah, we met. We just came back on leave of absence, right?
Yeah.
Like 6 months.
Is that right?
I'm not doing HIPAA here because it was on social media. But yeah, he had a heart transplant.
Wow.
He had a viral infection. A viral infection that destroyed his heart muscle. And I was like, how did you even get a heart? I mean, people that have heart transplant, it takes them a while. And I was like, man, that is crazy.
Wow.
So that's what I'm saying. Am I getting old?
No, not you. No.
Well, this is old. When you're sitting down with your friends and they're talking about what drugs they're taking. like blood pressure drugs.
Yeah, not the fun drugs.
Yeah.
Those are in the past.
But it's scary. I'm not there yet, but I mean, it's scary to think about that because I have a lot of friends that are going through that.
Oh.
Okay, advanced cardiac life support medication. Again, be familiar with these common drugs that you're going to find in your crash cart. So, epinephrine, dopamine, atropine, lidocaine, sodium bicarbonate. I think we go through each here. So, epinephrine is most valuable and potential life-saving agent available for cardiac arrest victims. It makes the heart more sensitive to electrical conduction. Again, this is the first drug of choice when somebody's going into cardiac arrest or shock. Epinephrine.
I got a question.
Yes.
When you were at the hospital and the young man or whatever got shot, was epi not?
No, they were doing all that. So the chest compression was one thing. You had the nurse giving all the drugs, and so you do the chest compression, and they're setting up to do the defibrillator. And when they say clear, that's when I stop, and they clear and do the shock. We look at the rhythm, nothing happens, and we got to do the chest compression again. And I have the advantage is that when you're working in the cardiac cath lab, when you're doing the chest compression, you can actually see in the monitor the effectiveness of your chest compressions. So you can see the pressure that you're creating on the monitor, and you can also see the heart rhythm doing this as you're doing the chest compression, but the moment that I let go, it's doing this. Yeah. Okay, so increases the force of the heart contraction. It is a vasoconstrictor, so it does cause the vessels to contract for a more effective blood flow. Okay, so look over epinephrine, look over dopamine, supports and maintains blood pressure. It is a vasodilator as well. It does the opposite. It increases the blood flow to respective organs, minimizing any type of potential for shock. Now, it says vasodilator, but in greater amounts, it also becomes a vasoconstrictor. So it depends on what it's used for. So depending on the concentration, it can either be a dilator or a constrictor. Okay, and that's why it says here, it can also increase contractility and force of contraction of the heart. Okay, so depending on the dosage that they give them, it does one or the other. Okay, so it does both. Atropine, clinically indicated for cardiac arrest patients suffering from bradycardia or worst case scenario, asystole. So asystole, it may look like a flat line, but it's still receiving, electrical conduction, rather than the PEA. PEA is just straight out flat. There's nothing that you can do about it. And remember, when you're trying to shock somebody into a rhythm, it's only good if they have a rhythm. If they have no rhythm, defibrillating them does nothing. Okay? There has to be conduction going to the heart. So whenever you see in the movies they're flatlining and you see them doing that, defibrillator, that's not real. They gotta have some kind of rhythm for them to defibrillate. Okay? Because the defibrillator does is what it does is that it puts them back into a normal rhythm. That's the key. They have a rhythm, but it's abnormal, and that's what the defibrillator does. Okay? So atropine allows the sympathetic nervous system to kick into high gear, preparing the body for fight or flight. A series of internal activities are set off when the patient is faced with a threat in preparation of defending or fleeing its safety. So it increases the heart rate, blood pressure, and also the cardiac output. But I think we've been kind of talking about this mostly, okay? Or it's good for bradycardia, bless you. And then lidocaine is an anti-arrhythmic drug. Not the lidocaine that you use to numb up, like they put in your gums when they're trying to pull a tooth out. It's the same family, but this is in higher concentrations, okay, higher concentrations. It's an anti-arrhythmic drug, indicated for premature ventricular contractions. You guys are familiar with PVCs, okay? And ventricular tachycardia, and it's used to treat ventricular fibrillation when electrical shock fails. Now, when I worked in the cardiac cath lab, I have my own tray here, which is my own surgical tray. I have my instruments, I know where it is. Nobody touches it. The doctor is not even allowed to touch my tray, okay? Because I have it set up in a certain way. And I have lidocaine on my table, and the lidocaine is used to numb the area before we put a needle in there and put up our catheters. You guys follow so far? So I put it off, and I purposely do this. I put it off to the side so nobody touches it, including the doctor. I work with a doctor where he would constantly just grab shit out of my table, and it pisses me off because my table is set up in a way that I know how it is, and when they go fussing with it, it gets me upset. I'm kind of like that. So he would grab what he thinks is saline. Saline is water, okay? So I have that all over my table, and I put the lidocaine on purpose off to the side. And he's grabbing the lidocaine and injecting that into the patient's heart. And I said, you just injected lidocaine. And it was even labeled, it said lidocaine is injecting lidocaine into the patient's heart. I said, if you want something, tell me and I'll get it for you, okay? So he's trying to get saline again, but instead he grabs the lidocaine and injects it. I said, you just injected lidocaine. Okay, so the next time he did it, I did this. I said, what do you want? I said, what do you want? I'll get it for you. Because every time they injected lidocaine, I'm looking at the patient's rhythm. Because although it's just for numbing, you put enough in there, you can cause, rhythmic changes. So by the time he started grabbing it for the third time, I said, I've had enough. You need to stop. Okay. Okay. When you work in the cath lab, you have a lot of control. Yeah, even with the doctors, you tell them what they can and cannot do to a point. Especially if it's endangering the patient, I'm going to step in and tell them what's what. Okay, sodium bicarb. Okay, good for hangovers.
We don't drink.
I'm looking over there. For a response from this group right here. Sodium bicarb. So again, this is an injectable form, indicated for acidosis in an anaerobic respiration, such as when having cardiac arrest. The body produces lactic acid. So this is good for acidosis. Okay, it helps maintain the pH balance of the body. Okay, so that the body can better utilize oxygen. Okay? All right. You got this, right? Tell me you got this. You know what this is. You got this, right?
Yeah.
Yes?
Yep, yep.
This is all just basics, basic rhythms. You got it, right? I'm gonna keep on going? Yep. Okay, look at this. Make sure you understand these, okay? Okay, you got it?
Yeah.
All right. Have you guys ever seen this video?
Oh my God.
Have you? Okay, this is the office, and they're teaching the office how to do CPR. Okay, let me just do this real quick, and then you guys can go.
So, assessing the situation, are they breathing?
No, Rose, they are not breathing, and they have no arms or legs.
That's not part of it.
Where are they? You know what? If we come across somebody with no arms or legs, do we bother resuscitating them? I mean, what kind of quality of life do we have there?
I would want to live with no legs.
How about no arms? No arms or legs is basically how you exist right now, Kevin. You don't do anything.
All right, well, let's get back to it, because you're losing them. Okay, too fast. Everyone, we need to pump at a pace of 100 beats per minute.
Oh, okay. That's hard to keep track. How many is that per hour?
How's that gonna help you?
I will divide and then count to it.
Okay, well, a good trick is to pump to the tune of Staying Alive by the Bee Gees. Do you know that song?
Yes, I do. I love that song. First I was afraid, I was petrified.
No, it's Staying Alive, Staying Alive.
You were in the parking lot earlier. That's how I know you.
Staying alive, staying alive. Staying alive, staying alive.
You can't tell by the way I use my walk. I'm a woman's man, no time to talk. What is it now? Women more been kicked around since I was born. Well, it's alright, it's okay. You can look the other way.
Staying alive.
You did maintain 100 beats per minute, and the ambulance didn't arrive because nobody called 911, so you lost him.
Okay, he's dead. Anyone know what we do next? Anybody? Rose?
I have no idea.
Anyone else?
We bury him.
Wrong. Check for an organ donor card. If he has one, we only have minutes to harvest.
He has no wallet. Check.
He is an organ donor. He is, yeah. Give me some ice in a styrofoam bucket. We search for the organs. Where's the heart? The precious heart.
I'm not feeling well. I need to sit down.
Hey, first, please. Are you okay?
Can you tell me why you had to cut the face off the dummy?
I didn't think it was very realistic in the movie. And it turns out it's pretty realistic.
You had to pay for it. It cost us $3,500.
$5,300 for a dummy?
Wow.
Okay, look, David, this is why we have training. We start with the dummy, and we learn from our mistakes, and now Dwight knows not to cut the face off of a real person.
So, just by the way, somebody was on the news, I guess, last week because they did save somebody's life and they remembered this video. Yeah, so yeah. So remember that. Staying alive. All right, guys. Next week we'll see you. Again, no lab Monday or Tuesday. Okay, guys.
Okay.
But we still have
Wednesday.
class on Tuesday for the other classes. For those who have radio bio and the other stuff. Okay. I'm just talking about lab. All right, guys.
Right.